In recent years, vaccinations have protected more of the world's population than ever before, contributing to increasing life expectancy and economic growth. The range of vaccines has expanded to now more than 20 to protect against 20 diseases and more. And vaccines are also available faster than ever before for low and lower middle income countries. Now, the power of vaccines has become further highlighted by its role in the fight against COVID-19 pandemic. However, prior to the pandemic, immunization coverage has flatlined for the past 10 years, and almost 14 million children did not receive even the first doses of vaccines. While immunization has been severely disrupted early in the pandemic, it did show quick recovery. However, 1/3 of countries are still reporting disruptions in immunization services 1 year after the pandemic. We are at a critical juncture where a new roadmap for the next decade of immunization has been launched, the Immunization Agenda 2030, with a vision of leaving no one behind. Today, we will focus our discussion on the Immunization Agenda 2030, its core principles of people-focused, country-owned, data-enabled, and partnership. What needs to be done to achieve the goals and the vision and the objectives? Our discussants will share their expertise and perspectives on immunization program for universal health coverage and primary health care. The discussion today is to activate the rollout of the IA 2030 roadmap for the decade ahead. Good morning, good afternoon, good evening. My name is Falake Olainka. I'm the co-chair of the Immunization Agenda 2030 Working Group on Immunization Programs for Universal Health Coverage and Primary Health Care. I'm also the immunization team leader at USAID, Global Health Bureau, based in Washington, DC. I will be your moderator for today. Welcome. With that, let me share a few highlights from the Immunization Agenda 2030. As you can see on the slides in front of you, we are all embracing a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. In the next slide, we'll highlight what is new in the Immunization Agenda 2030. There are a few things on the slide here. This was a bottom-up co-creation approach led by WHO, supported by UNICEF and other global partners. It's promotes tailoring and implementation to the country context. It's targeted to address inequities. It brings a stronger systems focus. It also highlights a life course approach to access vaccines equitably at all different stages of life. This is just to mention a few. It also focuses on accelerating innovation and sustainability. In the next slide, I'll take us to focus on one of the strategic priority areas. But here you can see there are 7 strategic priorities. The first one is immunization programs for primary health care and universal health coverage, which is an umbrella strategic priority area for the other 6 priority areas. The second one I'd like to highlight is commitment and demand, coverage and equity, life course and integration, outbreaks and emergencies, supply and sustainability, research and innovations. These 7 strategic priority areas form critical areas of focus in the IA 2030 strategic framework. There are 4 principles: people-focused, country-owned, partnership-based, and data-guided. Our panel today will be focusing on a deep dive around the Immunization Agenda 2030, with a specific focus on immunization programs for primary health care and universal health coverage. With that, I would like to introduce our keynote speaker for today. And I just will introduce her with these few words. Kate Crawford is the Director, Office Maternal and Child Health, Nutrition, Bureau for Global Health, USAID. Kate Crawford is a Senior Foreign Service Officer who most recently served as the Tajikistan Country Director. She has more than 30 years of field experience in complex development, humanitarian assistance, and interagency initiatives and programs. Throughout her career, she has held posts in USAID missions in South Asia, Southeast Asia, and Africa. I am delighted to welcome Kate to provide a few remarks to kick us off on our discussion today. Over to you, Kate.
Thank you, Falaki. Very kind. And I'm really honored to be here with this incredible group of panelists and the expertise here in this meeting. Obviously, okay, it's maternal, newborn, child, health, nutrition, all, but I gotta say my heart is really with immunization, primary health care. So this is a real honor for me, and very timely to have this discussion on integrating immunizations into primary health care and universal health coverage, particularly at a time where many of us are sort of facing a tsunami of resources due to the COVID pandemic, which we have not seen in many years. So it's incredibly important that we use this wisely into the future. Again, I am a huge supporter of vaccines, immunization, and have seen over the course of my career growing program gaps and growing reductions of vaccine coverage rates, which I find deeply concerning. So one of my priority goals in this tour in Washington was to really get USAID to focus on re-energizing its immunization work, which was a little bit of a tough task in the beginning, but none of us had any idea that a global pandemic would be upon us. And it's been devastating in many ways, but it's also served as an opportunity. Now the focus on vaccines, primary health care, equities, it's front and centered, and there are enormous resources behind these efforts at this point. So the pandemic has not only advanced vaccine research, but it's really supercharged all of these international program efforts. It's as if everything's on steroids right now. So I think it's important we really look at this wisely as to how we can use it best into the future. I'm going to speak specifically to sort of USAID's work and USAID's vision, because you have a panel of experts here who really understand the global situation much better than I do. I would like to acknowledge USAID's 60 plus years of work in vaccine, both in supporting the development of vaccines as well as in the distribution and strengthening of vaccine systems around the world. And then our more recent, but already 20-year relationship with Gavi and the kind of results that has had globally. So at this point, I'd say our commitment is deeper than ever, growing faster than ever. And we look forward to hearing from you, the panelists, as well as the participants, how we really begin to address some of those intractable difficulties of disparity and reaching the hard to reach and all the rest. In terms of the pandemic, I don't want to dwell on the devastation. I'm pretty sure everybody hears about that daily. I do want to touch on the fact that it has accelerated and opened up this incredible era of vaccine development with gene-based and mRNA technologies, which is incredibly exciting. So I think, this is game-changing technology, and it's going to be, the challenge will be for us to work collectively, collaboratively, to seize this opportunity to refocus and rebuild national immunization programs as the backbone of primary health care. The new vaccine technologies, I think everything is just opening up now. Yes, there's this global worldwide rollout of COVID-19 vaccines, but I believe on the heels of that, we're looking at using national primary healthcare and immunization systems and their platforms to very soon potentially roll out vaccines for malaria, possibly HIV, and other crippling diseases. So these platforms, these systems, and their reach are essential, I think, going forward to progress. It's very exciting. I do think that there will be challenges in assisting countries to address particularly inequities in vaccine access and primary health care. So I look to many of you to help guide us through these next few years. IA 2030 is a beautifully comprehensive global roadmap that aligns all partners in realizing a world where everyone at every age, irrespective of where they live, has access to life-saving vaccines. So the integration of quality primary health care, which I see immunization as the backbone of primary health care, and the advancement of universal health coverage will be key to achieving the goals and aspirations of IA 2030. So there is a lot going on internally at USAID, as many of you know. We have made some huge commitments, initially in COVID, but these commitments, I think, will have far-reaching effects. We remain a deeply committed partner with our key global partners, particularly Gavi, WHO, UNICEF, and others. I think what's most exciting is that we, I think, have re-energized or are re-energizing our vaccine work and really using now for the first time the reach of our field mission programs, our in-country project platforms and expertise, and our country and international expertise relationships to really look at achieving immunization goals, part of IA 2030. So we look forward to working with you. We look forward to learning from all of you. And I think before I just turn this back over to the panelists, I do want to acknowledge Falaki as our team leader. We have now the strongest immunization team USAID has had for many, many years, and it's growing. The team is incredibly busy right now. So a huge shout out to the team and their work. I would also like to just leave the participants with a couple of consideration and questions that you can mull over and perhaps discuss as the morning wears on. But I guess we need to understand better the root causes of under-immunization and how we can better tailor local actions to address these root causes. And we need to look at what program shifts, learning, and innovations are needed at all levels to put people at the center of these efforts and use data to drive actions to ensure quality essential services are accessible to all. So I very much look forward to the conversation. Again, I am really honored to be asked to open this. It's I'm deeply committed to immunizations and primary health care. So thank you again, and I look forward to the discussion.
Thank you very much, Kate, for those opening remarks. You have really sparked our conversations today with those comments that you have made. At this time, I have the distinct pleasure of introducing our panelists. Um, and I would like to introduce the incredible lineup with the first person I'd like to introduce is none other than Dr. Kate O'Brien. She is the Director of Immunization, Vaccines, and Biologicals Department at WHO. Dr. O'Brien also serves as WHO's technical lead of the COVID vaccine pillar, COVAX, a part of the Access to COVID Tools Accelerator, Act A. Prior to joining WHO, she was Professor of International Health and Epidemiology and Executive Director of the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. The next discussant I'd like to present to you in the next slide is Dr. Feng Zhao. He is a practice manager, health, nutrition, population, global unit, World Bank. Dr. Zhao, in his role as the practice manager, he oversees the bank's global health engagement program and is leading a strategy of refreshing exercise for the bank's health population nutrition program. He has more than 20 years of experience in public health, medicine, economics, and demography. He serves also as a faculty member for a number of universities, including as faculty member for Harvard Finance Minister Executive Leadership Program. The next person I'd like to introduce in the next slide is Dr. Abubakar Campo. Dr. Campo is a medical doctor and public health specialist who currently serves as the Director of Health Program at UNICEF headquarters. With over 20 years of experience in development and humanitarian assistance, Dr. Campo has worked as a physician and surgeon in hospitals and clinics in Africa and Asia and brings direct 14 years experience in senior management positions with different agencies. In my next slide, I am delighted to introduce Dr. Suraya Dalil. Dr. Dalil is the director of WHO's Special Program on Primary Healthcare, a new program established last year. She was previously the Minister of Public Health in Afghanistan from 2012 through 2014, and Acting Minister of Public Health from January 2010 to February 2012. Dr. Dalil was Ambassador and Permanent Representative of the Islamic Republic of Afghanistan to the United Nations and international organizations based in Geneva, and Ambassador to Switzerland from October 2015 to March 2019. Her profile encompasses humanitarian leadership, health expertise, and diplomacy. In my next slide, I am pleased to introduce Dr. Mohammed Haq. Dr. Mohammed Haq is Line Director of Maternal, Neonatal, Child, and Adolescent Health, Directorate General Health Services at the Ministry of Health and Family Welfare for Bangladesh. He is a medical graduate with postgraduate degrees in public health and has been working in public health field for the past 30 years. His expertise and experience in rural and urban settings in the implementation of government programs and policies related to maternal, newborn, child, and adolescent health is really highly welcomed. He is currently leading Bangladesh programs on immunization, maternal, neonatal, child, and adolescent health at the national level. With this lineup, I'm really pleased to start off the panel discussion today. At this point, I'd like to really encourage our audience to feel free to go ahead and put in the questions and answer box at the bottom of your screen. So a little box at the bottom of your screen. It's Q&A. Feel free to put in your questions throughout at any point on the discussions today. The questions that you provide in here, we will be pulling them into the conversations throughout our conversation. So from time to time, we will pick your questions to make sure that we can cover them and respond to your questions today. So with that, I would like to kick us off with my first question. And this will be to Kate Crawford. Kate O'Brien. Let me correct that. Kate O'Brien, can you provide some of the highlights of the IA 2030 and what you think are some of the critical shifts that this new global vision and strategy brings for the next decade?
Thanks so much, Faloke. Your introduction really provided some nice framing of how IA 2030 is different, but there are maybe a few things that I'd like to emphasize about it. I think that there are several things that show up in the visual that we have for IA 2030. And of course, a visual is just an expression of what people really emphasized in the design for the strategy. And so these are the things that I really want to point out. We're moving from an immunization strategy in the past decade that was really about and achieved enormous things. It really was about vaccine introductions, really trying to narrow the equity issues between countries that were using life-saving vaccines that were novel, and those were largely high-income countries, and making sure that those vaccines that are in fact have the greatest impact in lower income settings with higher disease burden were introduced with efficiency and were able to be available in terms of access. Where we're really moving in this decade is, again, an emphasis on the equity agenda, but it's very, very much about the equity of access to all vaccines and equity in coverage. And that really means having to emphasize the most local level, because that is where the solutions are. We're not going to get solutions that are coming from a top-down approach, and we're definitely not going to get solutions that are sustainable, durable, and are resilient if we're only talking about immunization agendas. So for me, the things that are really different here is, first of all, the co-creation that led to this vision and strategy. This was not a process that largely put agencies or institutions in a room to try to identify what those really critical solution spaces are, but it was created around the world by communities, countries, CSOs, NGOs, as well as the agencies, where all of this expertise lies, and really got out of just the immunization programs and into the voices of programs that are serving families and communities that we clearly need much more linkage in order to serve them with the entirety of what families want. So I think that's the first thing. We're really emphasizing this diagonal approach. It's about strengthening the systems that allow for immunization programs to deliver, while at the same time being very focused on the impact that immunization programs can have, very quantitative, but allowing countries to specify where on that trajectory towards those goals they are. Not every country is going to have the same set of goals. And I think that was one of the gaps that we had in the last decade, is the goals were aspirational. However, some of them had already achieved them even before the decade started, while for other countries, it was clear they were never going to be able to accomplish those goals in the decade. So the goal setting is really about being on the trajectory. And then I think that the two other things that I'd really like to comment on is the emphasis on the strategy to be people-centered. I can't emphasize that enough. As any of us who are sitting in this room who have recently either accessed a vaccine or who are parents and have the experience of accessing vaccines on behalf of our kids, that responsibility that we have, or have accessed adult vaccines outside of recent events. Everybody knows that you've had good experiences and you've had bad experiences. And the bad experiences are inconvenient. Sometimes they're extremely time consuming, they're frustrating, and they don't instill confidence in the system. And so this idea that immunization programs have to deliver people-centered services, that is what allows for that great confidence in the products themselves and in the program to sufficiently and adequately on time, every time, in ways and places and means that make sense for the lives of very busy people is really important, I think, for making the advances that we are. We're really plateaued we're sort of stuck at a certain coverage level, and the next advances are going to be difficult. And then the final point is around partnerships and being data guided. And again, I think getting the partnerships outside of just the immunization partnerships, we need everybody with their oars in the water rowing in the same direction. And the immunization community needs to be part of that also for other programs, and especially for primary healthcare. So to me, those are the sort of grounding aspects that are really going to be the shape shifting and the impact shifting aspects of the strategy for this decade.
Kate, you highlighted some really important points in terms of what is different and important shifts that need to be made for the next decade. We're at the beginning of that decade. Can you speak to the issues around leadership? Leadership to be able to have the kind of impact that you are describing and that it sits within the IA 2030?
The leadership issues are leadership in definitions that are very diverse. The very first level of leadership is community leadership. And we've designed IA 2030 so that the ownership and accountability of the strategy is primarily held by communities and by country governments. That the ownership and the accountability to actually achieving these goals has to sit where the actions are really needed, where changes in programs are needed as a result of looking at data, understanding where the gaps are and where the progress needs to be made. And that sits at the subnational and at the national level. Added to that are certainly regional ownership and leadership roles and global ownership and leadership roles. But I think the real focus here is on the leadership of programs, financing, budgeting, community action, demand and confidence, all of those aspects that means there's leadership across so many different communities that value vaccination and are going to do the things, take the action that is needed from their perspective to actually contribute to the program. The challenge here is in this very difficult time that we're in, at the national level, leadership of immunization programs are really diverted in terms of their attention and are frankly overwhelmed in just about every country towards supporting their countries in a successful, massive program to deliver COVID vaccines. And so I do think that we have some concerns, frankly, in every country around the world, that attention towards high-risk populations, which are largely the untraditional sort of audience for immunizations, is going to either be left out or is simply just not going to be able to be successful. So the speed and breadth of the endeavor that we're on right now is a really unique opportunity and a risk for IA 2030. And I think this is something we really have to have our attention on from a leadership perspective, that we don't have so much focus on COVID vaccine that we're actually undermining the foundation of COVID vaccine programs and rollout to the detriment of the overall objectives of IA 2030.
I'm going to pivot a little bit and bring in Dr. Abubakar Campo, who has asked us to call him Abu. So Abu, we cannot achieve IA 2030 without the right capacities and the health workforce. We also know that globally, there's a projection of a shortage of 14 million by 2030 in terms of the health workforce. And we know that the pandemic has further reduced and devastated over 100,000 health workers, resulted in their deaths. So, how would this affect immunization programs in the next few years? And what do you see are some of the key considerations for us to overcome the shortage in the needed health workforce? Abu, over to you.
Thanks, Folake, for raising the issues of human resource for health. I think Kate said initially in her opening remarks that it is a people-centered approach of the IA 2030. And when we talk about people-centered, it's not just about the beneficiaries, but we also need to look at the service providers themselves. And we shouldn't be just blaming the pandemic of the shortages. I think we have been lacking of really investing in human resources for quite some time. We have left it in many cases to the governments themselves, while we would like to do everything else. And I think it has been a mistake. At the end of the day, no commodities, will find their way into a human body without human resources. No tools will be implemented without having necessarily the human resources. And it's not just a lack of human resource for health. It's actually the right motivations for those staff to actually implement what they're supposed to be doing. So I think the real questions which we all should be asking ourselves, how do we, in the next couple of years, we are building up, the human resource capacities to implement, a primary healthcare package in which basically, as Kate Crawford has basically said, immunization is the backbone of primary healthcare. So I think it is extremely important, that we're not just looking at strategies and commodities or new innovations, but we're really building on what is our most precious, resources within the health sector, which are basically our staff who are supposed to be delivering. And it's not just the staff who sits in the facilities. When we're talking about primary healthcare in particular, we also need to include community health workers, which are basically the bridge between the community and the fixed institutional facilities, which needs to be embedded and also be strengthening and as well institutionalized to really make sure that you can deliver on the promises that we're giving to everyone in terms of delivering universal health coverage.
Abu, you've really provided some important perspectives there. And maybe at this point, I will also invite Kate, if she would like to add a few words or comments, perspectives to that as well.
Yeah, I think the health workforce issues couldn't be more front and center right now. But it really speaks to the fact that we've been relying on health workforces in many countries that are volunteer health workforces and an informal health workforce. And that is certainly of high value, but it also is not necessarily sustainable, resilient, and the health workforce that's needed for the range of what needs to be done if we're really going to leverage immunization programs for primary health care and primary health care for immunization programs. The second thing I would also just add to this is when we look at the sort of expansion of the range of antigens that health workforce is expected to deliver, the knowledge that they're expected to have about the different vaccines, and the range of age groups that are being provided with vaccines now. And we're really, of course, in IA 2030, this advancement on a life course approach means that the health workforce that's involved in or needs to be involved in vaccination is a really different and expanded workforce compared with it's easy to sort of compare to 30 years ago or 20 years ago, but frankly, even 10 years ago. This engagement of adults in vaccination is something that anybody who works in vaccination has been really prioritizing and trying to get some bandwidth on. And here we are in a pandemic where this is the #1 health issue and frankly, social and economic issue in the world right now. So we've gone from famine to feast in a way, and I think we do have to focus on who those healthcare workers are, what training and remit they have to incorporate the vaccination programs into their daily experience.
Kate, you really provided additional insights into the health workforce issue. Let's take that a little bit further. We know that the last few years, there has been incredible progress in immunization, but we know it has also flatlined. This is prior to the pandemic. Can you share your perspectives on why we are seeing this flatline? And I'm going to also draw in Dr. Dalil into this question, just to re-mention that Dr. Dalil is the director of WHO's Special Program on Primary Healthcare. And we'd love to hear from you from the dimension of primary healthcare, your thoughts. We are trying to spark conversations that really brings immunization programs and primary healthcare closer together. But Kate, we'd love you to start in terms of why are we experiencing this flat line? And I'd like Soraya to come in thereafter.
Well, the flat line is really largely about children who don't receive any vaccines through the routine immunization program, what we refer to as zero-dose children. And of course, this concept exists in all public health programs. The terminology is not quite the same in other public health programs, but this is really what the flatlining is about. Kids who get started with immunization largely end up at least getting to 3 doses of DTP. And there are really sort of 4 archetypes that we have pretty clear sightline into right now about who these kids are, why they are zero-dose children, and some of the really important strategies to try to reach them. I'm not saying it's easy. If it was easy to do, if there was a quick fix to this, we would not be flatlined on DTP3 coverage for a decade. So this is heavy lifting, and it's going to cost more money. We have some new recent estimates about what it might cost actually to go beyond what is being achieved already on a per child basis. And it's probably something around 3 times more expensive per child to vaccinate those kids who are not at this point receiving vaccines. And I want us all to just recognize how hard it is to quantify something you're not doing or not achieving. This is actually not a simple number to come across and to figure out what does it actually cost to immunize kids who are otherwise zero dose. They're zero dose because we don't access them. But we're starting to get some evidence around that. So it does cost more money. And yet, of course, the return on investment, if we're just thinking about it from that perspective, is still enormous for delivering a full course of vaccines to kids. You know, a return on investment of somewhere around $50 for every dollar invested. So the reason that we're flatlined is largely because these are kids who are living in really difficult communities to access consistently. Remote rural is a sort of archetype that we've recognized for a long time. Just challenges in physically being able to identify, especially kids who are in pastoralist communities. But new evidence is also showing that, in fact, this rural concept, the majority of kids live within a mile of a facility. So yes, they're rural, but they're not inaccessible. They don't have a lack of access. It's not that the facilities are so far away, it's that there isn't an access point for them to get to them. The second are kids in conflict settings or vulnerable, fragile settings. Real risks for both the healthcare workers and for these families, highly vulnerable children and families. And then the third is the a trajectory that we're on for an escalation in urban slum areas. And families, children who are living in urban slums are in some settings very marginalized, marginalized people, marginalized communities, may be undocumented, may not want to be recognized by the system, and the government may not want to recognize them. So a really, a difficult setting to monitor, identify, track, and consistently immunize those children. And then of course, gender crosses over all of this, and the importance of gender in all the different ways that gender plays out to make it difficult to not facilitate, where our systems do not facilitate actually accessing kids and making it, again, people-centered. Who are the people who bring children to immunization communities, immunization settings? And largely these are women in many communities, but they have constraints about whether or not they can achieve what they're trying to do for their kids. So those are, I would just lay out, those are sort of the 4 archetypes of why we're flatlined at this point, and the sight line that we now have through data, through technologies for identifying where these kids are and actually achieving vaccination of them, and that being the entry point for a whole range of other services that they have need for as well.
Dr. Devi.
Would you like me to come in?
Yes,
Okay,
please
thank
come
you.
in.
Thank you. Greetings to colleagues, friends, and participants of this discussion, this webinar. Thank you very much for the opportunity. I'm honored to be part of the panel and learning and contributing to this discussion. With regards to flatline immunization coverage, I think the driver behind that is inequality. And that inequality includes exclusion, poverty, social and gender norms, and also fragility, conflict, and violence. I want to here expand on issues related to conflict and fragility and violence. The UN reports demonstrate that conflict and fragility in terms of its nature and characteristics have changed in the last few years. We have conflict in the world that's more brutal, protracted, chronic, and you do not see conflict or active armed conflict between states now, but you see more domestic groups fighting with each other, and you see proxy wars and so on. So we have seen systems and national health systems that are deteriorating, and it's very hard to bring them back on where they were. And that affects programs, that affects service delivery, that affects coverage, that affects access. So it's multifaceted, the conflict, it's prolonged, and it's brutal. And it adds to other drivers we have, including poverty and exclusion. So I want to highlight that one. I would also like to say that the UN estimates that by 2030, fragility, conflict, and violence countries will be home for 2/3 of the world's extreme poor. And I think we need to find solutions, and as Kate referred to it, local solutions, local innovations, to find ways that despite the conflict, we keep reaching children, and we keep reaching not only children, but also families and communities. I also want to bring to speak on the health workforce that previous speakers touched base on that, and I want to add, from a primary healthcare perspective, we are promoting multidisciplinary workforce at the primary healthcare level. That includes nurses, midwives, family physicians, general practitioners, pharmacists, vaccinators, as well as social workers, psychologists, and so on, that they're well trained, they're well equipped, including water and sanitation, and they are connected to technology, and they're working in teams and in networks. And I think that's applicable across the countries, and that is where we need that. It will bring a larger benefit. With regards to, and then from a primary healthcare perspective, we are also advocating a situation where your staff and your multidisciplinary staff at the primary care level are connected with other stakeholders at the community, including municipality, including schools, including food and agriculture, including local transport, including trade department, and so on. So they are working in coordination in a multidisciplinary way, because we have seen that the frontiers between being healthy and being sick, the frontier between communicable diseases and non-communicable diseases, the frontier between physical health and mental health are blurred. So that's why we need to focus on risk factors and on social determinants. Let me also add the human rights approach, the human rights perspective, because health is a fundamental human right. And we need to look at our programs from that perspective. And I'm very glad that IA 2030 has taken that into account in terms of the principles that you have highlighted in the agenda. But what's important for governments to have that into their decision making is that if you look at health from a human right, from a basic human rights perspective, then you do not look at health as a cost, as a privilege. You look at health as an investment, and you look at health as a necessity. And that's why then your perspective on healthcare financing, on designing health insurance, on providing, on reaching out to the population, wherever they are, and whenever they need you, takes another paradigm. So there's a paradigm shift in that if we look at it from a human rights perspective. So I stop here, and I'm sure I will come back to other issues. Thanks.
Soraya, you have been very provocative in your comments for us to look at really the interlinkages, look at complex vulnerabilities, and also the way we look at costs for health, looking at a paradigm shift based on human rights. Thank you very much. I'm going to shift gears a little bit and turn to Dr. Feng Zhao and really try to elicit your perspective around systems. We know that the pandemic has really affected the existing immunization systems, broader health systems in the past year. What are some of those new monitoring systems that have been put in place during the pandemic and opportunities that we see that are able to be adapted for immunization programs and primary healthcare programs going forward? Over to you, Feng.
Thank you, Falaki. It's always encouraging to hear the visions from the two Kate, the vision presented by Kate Crawford on the USAID AID support to global immunization program, and Kate O'Brien's vision insights on the IA 2030. Of course, Abu and Soraya's intervention is always appreciated. Let me just touch on maybe some a slightly different angle. COVID hit the world with two angles. We are familiar with the health angle. I don't want to repeat all those epidemiological statistics and numbers, but there's also economic shock is going on, affecting people's livelihood. So that's why we call it the double shocks of the COVID-19. The economic shock is also equally profound. We estimated about 163 million people were pushed into poverty by the end of 2021, this year. This is after 20 years continuous poverty reduction, and now we are brought back to the level of 2015. So this is another angle we really need to look at it. One interesting phenomenon we have observed in this pandemic, which is unlike other crises, is when other crises, for example, the earlier financial crisis, when it hit us, so you see the GDP growth decline, you see the government revenue decline, and you see a decline in health spending. In the COVID-19, we observe a divergence in pattern, right? So we see there's an immediate surge in health spending to address COVID-related activities. But if you only look at numbers, it really didn't tell the whole story. The overall health spending may increase in some country, but the financing for essential services are heavily impacted. So the question is whether or when we can reach the pre-pandemic level. And the answer is not that straightforward. A lot of countries has increased their debt. The economic growth will take time. So in many countries, it will take a while for the country to reach pre-pandemic health spending level. Maybe in some countries they recover quicker, and the financing to COVID will bring some positive externality, but it's not a linear trend. There's a lot of uncertainties and questions. So there's a big question mark facing us in the financing on the road ahead. The double shocks definitely affect our immunizational programs. So I think there's some statistic, I think it's the Kate's team has been present those data. So 90% of the essential services has been reported one or more disruptions, right? So we know this is across the board. So immunization is not a vacuum. Now, how do we monitor this, both on the immunization side and on the economic side? I think we should build on some already exciting programs through some of the partnerships. For example, ACTA, for example, the joint work by UNICEF, WHO, and the bank on VRAT, VRAF. There's many exciting initiatives already coming in play. We should really expand it and build on that. There's an effort to harmonize the different tools, particularly through the platform of ACTA, and then pull our capacity together across different agencies so we can harmonize the tools and data set. The National Pulse Survey, for example, to highlight the disruption of essential services. The Vaccine Readiness Assessment, VRAT, VRAF, the integrated tool to monitor the readiness in terms of vaccine rollout, which now is already covered more than 140 countries, and Kate can provide more insight. And the Health Facility Survey, which is also taking off by Global Fund, Bank, and UNICEF, also will bring a lot of value to that. There's a need to integrate those tools and make sure we use it quickly for our own use. The last point I want to make is really from the bank point of view. Bank has responded this COVID crisis in a very unprecedented way, both in size and in speed. Right now, for the first emergency operation, we already have more than 100 countries have our emergency financing, which is really progressed very well. And the vaccine phase, we allocated 12 billion. Now we have 20 countries, over 2 billion is already in place, and we have 50 plus countries in the pipeline. And vaccine, we know vaccine supply is really a major bottleneck for the rollout to continue to move forward. One thing in our financing, we really pay attention is, it's not just about the tool, it's about the delivery system. You cannot just finance or procure vaccines without considering vaccination program. The immunization program has to be there. The cold chain has to be there. The human workforce, the health workforce has to be there, as mentioned by my final panel members. Now, the COVID immunization program will bring benefit to our routine immunization program, but the answer is not straightforward because the target population, the requirement on cold chain, and the scope will be different. So there will be some nuances we have to look into. And the financing, particularly on sustainable financing down the road, is really worrisome from our health economist point of view. So those are the challenges we have to face collectively. And this is why there's a need for the global community to come together on data, on strengthening health system, so we can make sure our routine immunization program will reach a new level. Over.
Thank you very much. I'm going to push you just a little bit on, do you think we can build to even better levels than the pre-pandemic?
I think so. I'm an optimist person. So the world has learned a lot how to build a resilient health system. For example, the bank's next year's flagship report will on resiliency in health systems in other social sectors. So this is the one area I believe we can do much better. As I mentioned, it's not given, and we need really the new knowledge and the details. For example, we have been talking about strengthening public health functions in primary health care, in the regular health systems, but how? What exactly we want to move forward? Where is the gap? It's still to be determined, and the detail still need to be provided. The surveillance system we have been talking about. Different countries have different gaps. How do we move forward on that? So there's a lot of details need to be strengthened. But overall, I feel with the financing on COVID and the financing on regular health systems, and those meaningful global partnership like IA 2030, UHC 2030, and now there's a lot of soul searching, particularly among our country leaders, health ministers, finance ministers. I believe the collective effort will prevail. I believe given time, our system will be stronger. It requires global level and country level work very closely together. Over.
Thank you very much. I'm going to turn to Dr. Mohammed Haq. He's going to ground all of us. We have been providing a lot of very high level policies and perspectives, but really hearing from the line director from the Ministry of Health in Bangladesh is absolutely critical in terms of pragmatic actions and country leadership. So Dr. Haq, I'm really excited to bring you into this conversation. I'd like to shift a little bit and really pick up from the last point from Feng. What are you learning from the COVID-19 pandemic and how vaccines are being rolled out? And how can we apply these lessons to improve our immunization systems at the country level, but also welcome you to provide perspectives to the global level as well? We want to hear from you. Mohammed, over to you.
Thank you. Polaki, respected guests, panelists, senior dignitaries, and participants from all over the world. Maybe it is good morning, good evening, or good afternoon. It is indeed a great pleasure for me to be part of this Immunization Agenda 2030 webinar. I think at first I want to say that the immunization world is now divided in two parts. One is COVID vaccination, routine immunization. So both are the challenges for us. And at the same time, we have to address both the things. And in Bangladesh, EPI, you know that expanded program of immunization, that is the basis of routine immunization program. And now we are addressing also the COVID immunization program. This roadmap for progress in global immunization systems, in new global vision and strategy for vaccines and immunization to be discussed on today's webinar. But I want to just address something that this is more important for us when COVID-19 pandemic has made significant impact on immunization. Bangladesh took extra measures to reach the children with vaccination who were missed due to COVID-19 impact. The coverage dropped by almost 50% in April and May of 2020, compared to same time period in 2019. We able to more than 90% immunization coverage in most of the districts. However, still there are missed children, while the pandemic has strained health systems as never before. The challenges of the COVID-19 vaccine rollout may provide learning opportunities that could ultimately aid countries seeking to enhance the provision of vaccine services across the life groups. We have completed our MR campaign throughout the country during this COVID situation, and our coverage was about 90%. But at the same time, for achieving the next decade goal, we need more workforce availability, which was addressed by Mr. Feng Zhu, and also the other for who would maximize the engagement of integrate primary health and universal health coverage strength, disease surveillance, supply management, safety reporting, and immunization records monitoring system. I want to inform you that from the very beginning of the pandemic, Bangladesh took countrywide measures to contain COVID-19 by forming different national and subnational committees, by strengthening disease surveillance systems to identify, isolate, and care for the patients, including tracing of the contacts. Appropriate steps were taken to prevent entry of COVID-19 cases from affected countries, to limit human-to-human transmission, including secondary infections among close contacts and healthcare workers, to prevent transmission and amplification effects, and enhance infection prevention and control in community and healthcare settings. Besides, steps are taken to communicate critical risks and counter misinformation in order to minimize social and economic impact through multi-sectoral partnerships. Meanwhile, capacity of the country to test and treat COVID-19 was gradually increased. Round-the-clock monitoring was done by communicating and collecting data from elsewhere of the country, and necessary feedback was provided. The country has the capacity of sentinel-based, event-based, community-based, and web-based, and cell phone-based surveillance. And this time, the capacity has been improved to meet the need of the country. We have identified some priority areas for planning and action, like coordination and planning, surveillance, laboratory and points of entry, case finding, contact tracing and quarantine, clinical case management, infection prevention and control, risk communication and public awareness development, and operational research. Afterwards, pillar committees were formed to address all these priority areas in collaboration with different development partners and non-government organizations. This pandemic has made many opportunities to strengthen our existing systems and to collaborate with partners to maximize our efforts in the next decades. We need to build on these learnings, on these achievements to develop a resilient health system. I want to inform you one thing, that Bangladesh has already started the COVID-19 vaccination. And in the meantime, we have from different sources, Bangladesh has purchased vaccine from direct contact, and COVAX is also supporting us. Probably within a few days, COVAX supply will be in our hand. And in the meantime, we have already vaccinated more than 6 million, near about 6 million people. And we are now running the second dose. And within a future nearby, we will start our another vaccination round for the COVID for COVID vaccinations. Thank you all. Thanks for.
Thank you very much, Mohammed. I'm not letting you off the hook just yet. I have a follow-up question for you, and I will also like Soraya to weigh in on this. We have a question from the audience, and this is really saying that this is wonderful to hear the significance of subnational leadership. There's an intent and willingness from the global level to listen, but what the audience is asking is, how are global immunization leaders adapting their behaviors and practices to make this productive and to avoid the risk of an echo chamber in which countries try to say what they think people at the global level want to hear? What advice do you have for global leaders in terms of being more supportive of national and subnational leadership? So I send this question to Mohammed as well as Soraya.
Yes, thank you. So this is the situation, and we are just implementing the program at this moment. But there is a lot of learning from us that good coordination is needed for every time, like the subnational level, national level, everywhere, and even in the primary healthcare level. You know that we have a good primary healthcare systems like community clinic and the HNFWC and Upazila health systems. And due to that monitoring system, it's a good system for us to monitor all the tiers at the moment. So if we can arrange the monitoring systems, as well as another one thing I want to say, that the country is totally addresses the situation like COVID situation everywhere, not only for the hospital management, but also the to cut out the patients situation. And also the country is very much eager about the vaccination. And our Honorable Prime Minister, she wants that everybody will be vaccinated. And this is his vision, and we are trying to achieve those goals.
Thank you, Mohammed. I'd love to invite Soraya to weigh in on leadership and also what advice to improve support for country and subnational leadership.
Okay, I would like to reflect on my own experiences from Afghanistan. And that goes back to 2003. So it started in 2003. And that was the way Ministry of Health was operated, or the way we delivered the services. We revisited the role of the Ministry of Health. And it was a joint work between the government of Afghanistan, the Ministry of Health, as well as our partners. So what we did, we shifted from provision of services to more stewardship and leadership function, defining the basic package of health services, costing the basic package of health services jointly with partners, and delivering that at a scale, at the national level throughout the country. I think that was a fundamental decision in terms of our own function. What we did in that shifting from service provision to more accountability and stewardship, we enhanced some of the key governance functions within the ministry in terms of coordination, health information system, procurement, and financial management. So we enhanced several-fold those key governance functions within the ministry and shifted the role of the ministry. Alongside, partners also supported us in a different way. They came in more harmonized and aligned way. They supported the basic package of health services across the country. And we also agreed on a mutual accountability between the partners and the Ministry of Health. And I say partner, and that basically includes mainly the World Bank, the USAID, and the European Union. And they also agreed to focus on results. So that is how we changed the practice and the behavior of both sides, the Ministry of Health and the partners. And that we have seen reduction in maternal mortality and child mortality, increased coverage, alongside immunization coverage and the basic package of health services. And I think that's a lesson that includes policy innovation, that includes data-driven approach, that includes equity, because equity was at the heart of this decision. We did not focus on urban population or versus people who are in major cities. We focused on women and children across the country, especially in rural areas. However, now with urbanization, with growing private sector, with comorbidity, including non-communicable diseases, and looking into an integrated life course approach, we are revisiting the basic package of health services. And we say, what is next? What is the next journey in this basic package of health services that started together? So I want to emphasize on that partnership, on multilateral partnership, on mutual accountabilities, and on the key governance functions for the ministries to have, regardless whether they are even in humanitarian situation, we need to support them to perform their key governance function in order for us to have that travel together. Thank you.
Very much, Soraya, for that. Let me take us a step further. One of the questions that we have from the audience, the participants on the call today, has asked us to provide more detail on how immunization could be integrated into universal health coverage. And I'm going to pass that question on to Dr. Campo. And also, if Dr. Feng would like to weigh in. Abu, would you like to speak to that question?
Thanks, Folake. I think to answer these questions, we should be talking as well about primary healthcare, because I think for me, for UNICEF, if primary healthcare is the vehicle for universal health coverage, immunization is the engine of this particular vehicle, because immunization is a very long-standing program. It has an institutional deliveries, but it has very early in the days also thought about, just institutional vaccination or in facility-based vaccination. We will not reach all those populations. So it started in outreach programs as well, where we have health workers going out into the community and reaching those children which we didn't reach before. Kate mentioned a very important concept, which is basically the zero-dose children. And I would like to emphasize here that in many communities where you have a cluster of zero-dose children, it is not just a lack of immunization services, it's a lack of an entire health service delivery system, which is not in those communities. You will also see that those communities are deprived of education, water and sanitation. There are many other deprivations which are there, which basically builds also to a distrust between those communities versus the existing, let me say, government-led social programs, which also contributes to hesitancies and not being compliant to adhere to some of the systems as well. So primary healthcare has as an objective, of breaching this gap. And when I talk about primary healthcare, or when we are talking about primary healthcare, we include the community healthcare component as well, which is basically the connector between the community and the first level of the health systems. Unfortunately, in the last few decades, since even the Almaty Declaration in 1978, the investment, as Soraya has been talking about, we should be talking about investment, has been much more at a higher level than at the primary level of health services. It is almost like somebody would like to construct a house starting from the roof. I don't know if anyone has succeeded of doing so, but that is basically what is happening when we're investing heavily in tertiary and secondary care, and we're leaving, on its own, community healthcare and primary healthcare level in this particular sense, which is basically also building trust. We should be looking at it as also building trust and really laying down the information. Now, how does immunization plays a very important role in universal health coverage? It's because immunization in itself has been for a very long time, the essence of primary healthcare, of reaching out on which many of the other services can be piggybacked. Not all of them, but definitely a large aspect of them. And we should be building on it. And that is why we do believe that immunization as being, one of the easily implemented activities, if we are investing in that, that can basically drive primary healthcare as a whole. But also we need to think about immunization as preventive medicine. And preventive medicines is actually the essence of primary healthcare in itself. So primary healthcare is not just a slogan. It is really something which is cost effective, which can drive down the cost of healthcare in general, not just for governments, but also for households. But at the same time, it needs to be expanded and can be implemented everywhere. Immunization is valid whether you're in a high income country or whether you're in a low income country. So is also primary healthcare, as we would like to talk about. And in this sense, if this is understood by everyone, it doesn't become a cost anymore, but it comes an investment in the future, because there's an economical aspect which Feng has very eloquently talked about a little bit earlier. And there's the health aspects in terms of really making sure that everyone will have access to a minimum package, whatever the package is in this particular countries. And this is where really we think that the IA 2030 should be investing itself of being the driving engines of primary healthcare to push primary healthcare to get to universal health coverage.
Very well said, Abu. Feng, would you want to weigh in on that?
Yes, just build on what Abu said. First, I just cannot wrap my head around if we talk about the UHC without talk about the immunization coverage. That just doesn't make sense to me. I have hard time to conceptualize that. I also like Abu's point. There's no UHC without PHC. So PHC, the way I say it, is the foundation of us reaching universal health coverage. So Abu have eloquently described that. What I want to bring in is the financing aspect. One thing we learned from COVID is the vaccine or the tools, essential tools, free of charge, has played a key role in many countries' response. Either they are covered by government spending or covered by the insurance fund that facilitated the quick response. The vaccine is the same, right? So they are paid not by the household and paid by the third party. That removed the financial barrier so we can achieve a public good. And this is a truly public good. Immunization is one of the best public good we ever had in our global health arena. So we should continue to build on that. Make sure the financial angle is there. Make sure we'll not push people outside the financial protection area and make them slip into poverty. This is another important angle from the universal health coverage to look at. Over.
Thank you. I want to ask if any of the other panelists would like to speak to the integration of immunization, part of primary health care and universal health coverage. How can that be really improved? Would anyone like to take 30 seconds to speak to that? Okay, so I am going to move us on into the last stretch of our conversation today. Really, this has been fantastic, and just want to move into accountability mechanisms. How can we ensure that the accountability mechanisms are actually effective in terms of prioritizing immunization within primary health care and universal health coverage? So I'll just do quick round the room. That is a question for everyone. At the same time, please tag in your last word for us today, for us to have the conversation for the decade ahead. What would be your most critical advice and recommendation for us? So I'm going to go around and just in 30 seconds, 40 seconds, please provide your last thoughts on these two aspects. And I'm going to go starting with Dr. Hack. If you would like to speak to those and give your last recommendation for the decade, or a recommendation for the decade ahead. Mohammed?
Just I thank you for achieving the next decade goal to leave no one behind. We need champions and workforce availability, who would maximize the engagement to integrate primary health care and universal health coverage, strengthen disease surveillance, supply management, safety reporting, and immunization records monitoring system. I hope this webinar would maximize adoption and engagement around IA 2030 for a roadmap to progress in global immunization system. And I acknowledge our co-partners, UNICEF, WHO, USAID, and everybody. Thanks, everyone.
Thank you very much, Mohammed. I'd like to turn to Soraya Dalil.
It's a very good question, and it's hard to answer it in 30 seconds, but I will underline a partnership, multilateral partnership, working together, alignment, harmonization, and focus on results. None of us can do this alone. Governments cannot do it alone in many countries. WHO cannot do it alone, and I think the solution, one solution, is to come together and work better together and invest in primary healthcare. WHO prior to pandemic recommended to all countries an additional 1% GDP investment in primary healthcare, whether that means reallocation or more expenditure on health. So I will stop here. Thank you very much.
Thank you very much, Dr. Dalil. Abubakar Campo.
Thanks, Folake, and I would agree with with Soraya and with Mohammed, what they have said. I think my final comments would be really that it is high time that we look at health and immunization not as a burden of expenditure, but as we look at this as an investment for the future of a nation. I think if we can agree on that, then it will make it much more easier if we start spending money on health. And I think Feng has probably much more accurate and up-to-date data of saying how much money we have lost just to the pandemic. If we had utilized this money to just to invest into the health sector, we wouldn't be in the situation of today. I'm pretty much sure that we would have responded to the pandemic much faster, much cheaper, and much more efficient than what we have right now. So I think for me is that let's us stop looking for low-hanging fruits and build the system as it needs to be built so that we are prepared for the next pandemic. And that's really, would be my final message. And I think the IA 2030 is probably one of the best tools of really investing in the health sector and making sure that we have the adequate human resource for health who can deliver on the promises, not just for immunization, but for the broader spectrum of health, which is basically primary healthcare. Thank you, Folake, for having UNICEF part of this wonderful discussions.
Thank you very much, Abu. Let me turn to Feng Zhao.
Yeah, very good question. 2 points. One is, I envisage we should have a stronger system, which not only be able to address crisis, but also can prevent crisis and address upstream factors, including animal health, environmental health, and have a quicker, rapid response system. So that's part of the resilient health system agenda. That's one. The second, even when we have a crisis hit us, we will be able to maintain essential services, use technology like telemedicine, use other means. And we need to identify a list of highly effective public good programs and protect them from service delivery point of view, from financial point of view, so they will be continue to provide benefit to the global citizen. Over.
Very well said, Frank. Thank you very much. And let me hand over to Kate O'Brien for the last word on the panel today.
Gosh, it's hard to go last because so many wonderful things have been said, but there are a couple things I'd like to add. There are a few words that came to mind when you asked the question, Folake. So I'll just run through them. The first is about backbone, and I think it's come out in documents, and it's what some here have said is that the immunization program has functioned as a backbone for primary health care services in many settings, and it continues to be seen that way and experienced that way. And a body is as strong as the backbone is, the core. So I think we want to focus on that idea. You asked about sort of the linkage with PHC and UHC. The second is investment. We do not ask of other sectors to deliver the kind of value that we ask health sectors to deliver. When we look at our defense sectors, we invest in a preventive fashion where we accept that there will be investments that will never be used. We hope they'll never be used, in fact. And we accept that there are massive investments that go into our defense sectors and other sectors that actually don't deliver return on investment the way we ask health programs to do that. So I also think that there is a financing budgeting argument here that we shouldn't be focusing on how do we carve up the health budget further and further. We should be talking about how do we expand the health budget. So this is just bouncing off the idea of investment. The third is around life course. I personally find that term a little bit of a boring term, but we do have some really, I think, impactful visions around and sort of vision statements around infant and childhood immunization. It's about protecting the adult in every child. And I think that phrase is so impactful for me. You really understand what immunizations are doing. They are protecting your future life. And we do have to have a much stronger program of protecting our older years when we're young adults. We have to protect our future motherhoods during pregnancy. So I think these concepts of what do vaccines do, they're not for today, they're actually for the rest of your life. And then two other concepts. One is on impact. And I think this decade will be different in terms of the achievements if front and center not the how we do it, but why we're doing it, is impact. And that just singular focus on measurement of impact and quantifying whether the things that we're doing, and when I say we, of course, what I primarily mean are country programs, are resulting in changes that are the desired changes. And when that isn't happening, with agility and with sort of dogged determination, we have evidence-driven courage to change and to try something else. And I think we have to have courage to fail, that not every change, not every effort needs to deliver success, but it does need to deliver the opportunity for success. And we will step away from those things that aren't delivering impact, and we'll move towards those ones that are showing that they are impactful, with a community of practice that I think we're trying to grow in a different way through IA 2030, so that those things that work can be transmitted, translated, and shared across communities and countries. We don't have to reinvent in each setting. So those are some of the ideas that that come to mind when you ask that question. Thank you.
Well, I'd like to thank everyone on the panel today, the two Kates, Soraya, Mohammed, Feng, and Abubakar. This has been a really important discussion, really setting the trajectory for the decade. I'd like to also thank our audience for staying with us. We're a little bit over. I really also want to thank the organizers planning behind the scenes, MCGL, USID in supporting this and their commitment. This is a strategy for all of us. And all the discussions today and positioning this as an investment, IA 2030, providing the pathway, but also looking at complex vulnerabilities, accountability, the impact that we can make collectively with partnerships, and also protecting the adult in every child. That's just a powerful statement. Thank you all very much, and have a wonderful morning, afternoon, and evening, wherever you may be. Thank you.